Now let's go into the test and let's talk about how it relates to, is it subjective, hybrid, or objective? Now remember, what are 2 or 3 of the main reasons that you need to know if a diagnostic test is subjective, hybrid, or objective? What are 2 or 3 of the main reasons that you would need to know that? Number 1, do you have all the categories to help support and fulfill the need for care for that case? Okay? What did I tell you? What did I say? The number 1 reason that you need to know the definition of a hybrid finding. Do you remember what I said that was? The number 1 reason, remember, that's one of the common ways that you're attacked with the defense attorney, the insurance attorney. It's one of the common things they'll say is, well, you only have subjective evidence. So one of the main reasons that you need to know the difference between subjective, hybrid, and objective, it automatically stuffs it back in their face. When you go, well, wait a minute, these are the subjective tests. These were the hybrid test, and these were the totally objective test. See, when you do that, you become an authority in subjective and objective. Do you see that? That's how quickly I destroy that argument. Now, obviously, I'll also have the documentation in all 3 categories. So it also gives you tremendous credibility and authority. It gives you authority when you know how to explain the difference. It gives you credibility when you have the documentation in all 3 of those categories. So this is real important. Let's walk through the common test right now, okay? Let's go through a series of tests. And let's go, okay, are these subjective? So here's the categories we want to look at. Is it subjective, hybrid, or objective? That's one category. The next category I want to ask, is it relevant? How relevant is that test going to be? And is it going to be a high sensitivity test or a low sensitivity test? Those are the factors we want to pay attention to. Is it subjective, hybrid, or objective? Is it relevant, highly relevant, or not relevant? Okay? And then is it a high sensitivity test or a low sensitivity test? So remember, what's a high sensitivity test mean, essentially? It means it's going to be normal at MMI. How valuable is that for you, the chiropractor or the patient or the attorney, to do a high sensitivity or low sensitivity test that's normal at MMI? How valuable is that? It's not valuable at all. How valuable is it to do a high sensitivity test that has high relevancy at MMI? Very critical. Critical. So let's walk through this so you kind of have it in your mind. Let's walk through, okay? So let's just go through some of these common tests these diagnostics, and let's see how it applies. You have to be able to explain this. When you're in front of a jury, I want my attorney to go, what's the difference between subjective, hybrid, and objective test, doctor? And I'm going to explain to the jury what that is, because what's that going to do to the jury? It's going to tell them, I'm the authority and I'm credible. Then I'm going to have the documentation in all 3 categories, and I just significantly enhanced building the case, because it's multiple pieces of the puzzle, not one, and I just totally eliminated the subjective only argument. That's what I just did. Just by knowing this. Okay? Okay, symptoms. Subjective. Totally. Objective, no. So here's what we want to do. Let's go through the test and go, is it subjective, hybrid, objective? Relevant. Is it relevant? Is it low or high sensitivity? That's your categories right there. Okay? Let's walk through all the common tests right now. Symptoms. Subjective. Hybrid? No. Objective? No. Relevant? Yes. Yes. Could be. Highly relevant. Low or high sensitivity? Low. Could be high, right? Depending on the symptom. right? Injury to the neck, my neck hurts right here. High relativeness. In other words, this is lower high sensitivity. So it would be low sensitivity, right? High relevance, low sensitivity. Signs. Well, it depends on the sign, right? But let's just say it's a common antalgic sign. Would an antalgic sign be subjective, hybrid, or objective? Antalgic. Huh?
Objective.
Oh, no.
You can see it.
Can the patient manipulate it?
It could. Okay.
It's not objective. The patient controls it. It's a subjective finding. Now, it's partial hybrid. Why? You have to interpret it. So it's partial hybrid. It's definitely not objective. Okay? I'm just talking about like antalgic. Okay. How relevant can that antalgic be? How relevant? Very relevant. Could be very relevant, right? Right? Low or high sensitivity? Low. Okay? Next. By the way, how important is a board like this to show in front of a jury? You know how far this will go? You know how far this table will go in front of a jury? You put all these categories up and on the top, and then you put all the diagnostics on the left, and you fill up all those categories. How relevant is this table? Could this table be to a jury? Huge. This becomes overwhelming to a jury when you do this. This is a fantastic jury tool. And what am I also doing with my credibility when I say, well, no, that symptom, it's only subjective. It's could be somewhat sensitive. It's definitely relevant, but it's not objective at all, and it's got low sensitivity. How much credibility did I just get with that jury? Remember, if to get something, what do you have to do? Give away something. Give away something. In other words, I'm putting everything in perspective. I'm not looking like what now? I'm not looking like I'm just going to bat for the patient. Because I'm saying things that aren't going to be helpful to the patient. But they're not going to drown me. Because it's a little piece of the puzzle and it's minor and it's out of the way. And I overwhelmingly have everything I need to put this thing together. You think you might want to share this with your attorneys? You think you might want to say, hey, here's all the common diagnostic tests. This is how it would play out in front of a jury. We just show them this. And this would put the whole dynamics together, create credibility, and put the relativeness of low sensitivity testing with subjective findings, put them in their relative perspective. I'll tell you, one of the things that I see, we'll cover this, one of the things that I see, a lot of these patients don't come in with neck braces and back braces, do they? So what does the jury see when they look at a typical soft tissue injury patient? Do they see injuries? Look at me. Does it look like I'm injured? Huh?
Nope.
No. So guess what you have to do to that jury? You have to explain the 3 different ranges of motion and how each one is different but is impacted in its relativeness and how it's affected by the science of the 3 phases of healing. I got to be able to explain to that jury why that person has no pain or discomfort doing this. But it's a permanent injury going to be the rest of their life, and it's very problematic. I got to be able to do that. That's what this helps do. Okay? This is a very good table. This table that we're going through right now is a very good table.
Would you draw this out or just?
Oh no, have it drawn out. I would just have it written out. Have the table written out, put it in your notes. Just keep it in your notes. Here's all the tests, and then put these right across. Subjective, hybrid, objective, relative, low or high sensitivity.
You can have the
Hang on the marketing part for it. Okay, let's go through the clinical part right now.
This is clinical in court. Would you have them ask you the question and how do you get?
Let me get to that. Okay, let's go through each one. But I'm trying to drive home how valuable this is. It's a different way of thinking. Instead of, what's the old way of thinking? Prior to learning this, you didn't separate it like this, did you? You just kind of clustered everything, didn't you? You can't do that. You got to separate out categories. Because when you separate them out, they become more valuable. And when you not only separate them out, you divide them out, they become even more valuable. Okay? And then put it all together. Now it becomes extremely valuable. Okay? Okay, mechanism of injury. Subjective? Is mechanism of injury subjective?
No.
Yes, unless you had a witness. Unless you had a witness.
Or a video.
Or a video. It's, other words, it's subjective. Now there's high correlative factors. Was there damage to the car, blah, 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 right? There's high correlation, but on its own, with nobody watching and no video, it's subjective. It's the person saying it happened. Okay? Relevance. How relevant is mechanism of injury? Huge. High or low sensitivity, mechanism of injury.
It's low objective.
Extremely high. Why? 75% of your diagnosis is from your consultation, right? 75% of your diagnosis should originate from your consultation. What's the one category in your documentation that gives you most of the information on the injury? Mechanism of injury. Mechanism of injury pretty much tells you the injury. What it doesn't do is give you the quantification for the injury. In other words, if you know anatomy and you know mechanism of injury, do you pretty much already know generally what the diagnosis or the problems are? Okay? So, yes. Mechanism of injury is highly relevant, highly sensitive. By the way, that's why, let's say there's a mechanism of injury and you can't explain it. How much of a disconnect is that going to be? That's going to be a big disconnect. That's why it's real important you can explain mechanism of injury with any potential injury magnifiers, and especially correlative, subjective, hybrid, or objective. You know how much trouble you're going to have if you got an injury and you can't connect or explain that injury to that accident? You got a big problem. You got a big problem. Okay, range of motion, active range of motion. Subjective, hybrid, or objective?
Subjective.
Subjective, but you got to interpret it, don't you? But the patient's got to do it. Active range of motion is not objective. Relativeness, how relative is active range of motion to the injury? High or low?
High.
High. Low or high sensitivity. Now this is at MMI, by the way. This is at MMI. Because anything could be sensitive when it's acute, right? I'm talking about at MMI, because that's what's most important. What is going to be positive at MMI? That's what's most important, not when they first show up. So active range of motion, high. High sensitivity at MMI. As a standalone, is it very important? Nope. Start surrounding it with mechanism of injury, subjective findings, hybrid, objective findings. Now we got a major piece of the puzzle. How relevant is active range of motion in a soft tissue injury at MMI? High or low? Well, it's low. You're not going to find it very much. Remember, active range of motions clear up, generally speaking. Active range of motions at MMI, active range of motions clear up, generally speaking. Passive range of motion with overpressure. Subjective? No.
Hybrid.
Totally hybrid. Totally hybrid. Objective? No. Can you see how if we divided up and did palpation and asked everybody to mark it, we'd have a lot of variables? That means it's not objective. How relevant is palpation? Now, when I say palpation, or not palpation, overpressure, active range of motion overpressure, how relevant is it to the soft tissue spinal injury at MMI?
Very.
Very. It's a major piece of the puzzle. Overpressure is because that flat out is going into joint dysfunction, aberrant joint motion. Is it a low or high sensitivity test? High, very high. That is the test. Overpressure motion is essentially the external way of finding joint dysfunction. It's the external way of finding it. High relevance, high sensitivity, overpressure. And guess how many chiropractors come into me and never even heard of overpressure and they're not even documenting it. I had one chiropractor did this. He learned overpressure and he learned how to document it. So he started including it in his re-reports. He calls me and guess what he says with the patients? This is making a ton of sense with the patients. When I was doing re-reports 2-3 months later, what did he have with low sensitivity, active range of motion, muscle test, dermatones, and reflexes? What did he have 3 months later? Nothing. He had nothing. Can you establish the need for care for that 3 months later? Does that mean you get paid? Can you still keep treating the patient? No, you got nothing. So he included a lot of these. Specifically, I remember this phone call. He called and said, I've included the overpressure range of motion, and he quantified it. Quantified it. And that was one of his major points of emphasis in the re-report. How much did the patient understand that? A lot. Understood it a lot. Passive. Joint range of joint motion. Subjective, hybrid, or objective? Joint motion's evaluated by what? X-rays. Totally objective. Relevance. High. Low or high sensitivity? High. That's the number one test, joint motion, for the number one injury. X-ray joint motion. That's the number one test right there. Altered intersegmental spinal motion or ALMSI. It's the number one test. I'm telling you, I'd write this board down. I'd put this down, put all your tests down. The attorneys you're working with, take them out to lunch. You go, let me show you what else we're adding. We're adding to our documentation support and walk him through all this. You're giving him gold right now. You're going, this is how we're going to support your case. This is how your case is supported. Because remember, you just need 4 categories fulfilled. What are they? Mechanism of injury, correlative subjective at MMI, correlative hybrid at MMI, correlative of objective. Everything else is, on top of that's gravy, but those are the 4 core that you want and need. Muscle strength, subjective, hybrid, or objective. When you do a muscle strength analysis, it's hybrid. You're interpreting that. Relevant. It's relevant to an injury, right? Low or high sensitivity at MMI? Low. It's almost always normal. 3 months, 6 months later, you're not going to have weakness 3 months, 6 months later. Reflexes. Subjective, hybrid, objective. Huh?
Hybrid.
Hybrid. You got to have a doctor interpret it. Relevant. Could be very relevant. Low or high sensitivity? Low. How many reflex problems do you have at MMI? None. Dermatones. Subjective, hybrid, or objective? Hybrid. Reflexes? Are relevance? Could be high. If it's there, it could be high. Low or high? Low. How many of you guys have aberrant dermatones at MMI with a soft tissue injury? You don't. That's called low sensitivity testing. Orthopedic test. Now I'm going to just generalize. We're just going to generalize because there's obviously a whole variety of orthopedic tests, okay? But I'm specifically going to say the joint orthopedic test. The joint orthopedic test, okay? So are the joint orthopedic tests subjective, hybrid, or objective? Hybrid. There's only one that I know of that's a totally objective test. There's only one. Huh? That's not objective. That's hybrid. You got to interpret that, don't you? Can he interpret a foraminal test differently than you? Can he even do the test very differently than you? Okay, so it's hybrid. What's the other reason I'm going over this? You guys will get trapped. Those attorneys will trap you by going into this, well, that's only subjective. Well, doctor, is that subjective or objective? They'll get you into thinking that a reflex or a dermatome or an active range of motion is objective. They'll actually get you to say it. You're trapped. As soon as you did that, you're trapped. You just lost credibility. They're trapping you is what they're doing. Okay? So, what's the next one? Orthopedic test. Hybrid. Relevance. How relevant could an orthopedic test be? High or low? Real high. Low or high sensitivity. If I'm talking about joint tests. Could be high sensitivity. Again, we're talking about joint specific tests. We can do a lot of tests that aren't relevant and that have low sensitivity. So I'm specifically saying, I'm pointing to the orthopedic tests that are specifically looking at joint dysfunction, okay? Static x-rays. Subjective, hybrid, objective. Objective, relevance. Could be highly relevant. Low or high sensitivity. Static x-rays. Low. Low. Dynamic x-rays. Motion x-rays. Objective. Relevance. High. Low or high sensitivity. High. MRI CT. Objective. Relevance for the low impact soft tissue spinal injury? Nope. Nope. Disc bulge? Yeah. Altered biomechanics? Are you going to order an MRI for altered biomechanics? Wrong test. Wrong test. That's like doing a motion study for a disc bulge. Relevance, MRI? If there's not a disc bulge, it's not going to be relevant at all. And most of the low impact injuries don't have a disc bulge. High or low sensitivity, MRI? Very high. It's not very relevant, it's very high, but it's not specific for intersegmental dysfunction. It's specific for disc bulge. That happened to one of my guys in court. They brought in an orthopedist, and the orthopedist put all the emphasis on an MRI. Well, that doesn't show up in an MRI. I actually couldn't believe, and this was a highly regarded orthopedist, that they brought in as a gun to shoot him down. And the orthopedist put all the emphasis on the MRI, not all the biomarkers. He was foolish enough to put everything into a positive or negative MRI. One biomarker. What did I tell you? What have I told you over and over and over and over and over? Never base your diagnostic or therapeutic protocol on one biomarker. You'll get trapped. Well, that's what this guy did. Guess how easily we shot him down. So my client calls me and goes, what do I do? What do I say? I go, well, number one, it's the wrong test. It's a static test, and the problem's dynamic. Number one. Number two, what else is wrong with the MRI? There's three big reasons with an MRI. Well, it depends on the settings. What if the settings of saturation of the color are altered or high or low? Will that change your diagnosis? Yeah. What about the slices of an MRI? Will that change your diagnosis on the width of the slices that it's taken? What about the angle of the MRI? Will that change the diagnosis? That's how fast we shot him down. I told my client, said, you say those four things. Made the expert orthopedist look like an idiot because he put all his eggs in one basket. He won that case. My guy won the case. let's say NCV and EMG together, okay? Subjective, hybrid, or objective? Objective. Relevant. It's not. It's almost always normal. High or low sensitivity? Well, it's not. Why are NCVs, now I'm talking about NCVs, not EMGs. Why are you guys get patients that have radiculopathy, right? You send them off for an NCV, right? How many times does it always come back normal?
Almost all the time.
Why? Does it mean because the patient's lying?
No.
They don't have any radiculopathy? Well, if they had radiculopathy and the test was high sensitivity, it would have picked it up, wouldn't it? But it's not. So it's not a high sensitivity test. Why?
It's testing different nerve fibers.
Say it louder for everybody.
It's testing different nerve fibers.
Remember, there's the fast twitch and slow twitch nerve fibers, the A and C nerve fibers. It's chronic is C, right? Chronic versus acute. It's testing the alternate. The radiculopathy is one nerve fiber. The NCV tests the other. That's why it regularly comes back normal, even though the patient has tingling and numbness in their arms. Did you know that before taking my class? Oh. Okay.
It's radiculitis then versus radiculopathy.
Yeah. Overwhelmingly, that's why they're normal, even though the patient has the symptoms and you do all the radiculopathy tests, Adsons, right? You do all the radicular tests and they're positive. You send them out for the NCV, normal, that's why. With the soft tissue spinal injury, so we know it's objective, relevant, not going to be, it could be if it was positive, but it's not. High or low sensitivity? It's low sensitivity. It's high sensitivity if that's what you're testing, but it's not testing the right, it's the wrong test for the wrong anatomy. That's why it comes back normal all the time. I used to test for 2 years. Radiculopathy patients, I never had one positive test come back. Have you guys ever had one positive test come back? That's how rare it is. It's very, very rare. By the way, that's another reason why you want to use the 5th edition guide. Because the 6th edition, for you to have an impairment, it's got to be quantified by electrodiagnostics. Well, what's the likelihood of you getting positive electrodiagnostics with radiculopathy after what we just talked about? Slim to none. But in the 5th edition, you're not required to have positive electrodiagnostics. All you're required to have is symptoms of radiculopathy with the associated findings. That's another reason why you want to use the 5th edition, not the 6th. Okay? What did I tell you the phrase was? Why are you going to use the 5th and not the 6th? It's because it's what? It's more relevant and specific for that patient. I just told you right there, in that example alone, it was more relevant and specific for the soft tissue spinal injury, wasn't it? In that neurological explanation we just did. Well, it's way more relevant and specific for joint dynamics than the 6th edition. It's more relevant and specific for that person's condition, and that's why I used it. And you have the ability to do it. Why? Because the AMA guide says it's based on what? It's a physician guideline. It's based on your experience, your opinion. Unless you have a state law that says, no, you're required to use this. And I only know of one state law that has that, and that's Oregon. And they don't even say the 6th edition. They have like a certain, they got really weird modified rules. So in all the states I'm in, all the clients I've had, all the offices, you're going to be totally fine with the 5th edition. You just stick with that, okay? Blood test. Totally objective, right? Well, that relevance could be dependent on the blood test, right? What's the most relevant blood test? Inflammatory index, high C reactive protein says there's something going on here, Okay? Now, it's not a primary, it's a secondary. It says something's going on. So it doesn't say this is going on, it just says something's going on. There's inflammation going on here. So it's supported when you add all the other information together. Low or high sensitivity? High sensitivity. High trust, high sensitivity. Okay? That's the high C-reactive protein. Sedimentation rate, I haven't found that to be true. Lipoprotein is an inflammatory indicator, and I haven't found that to be true too much either. High C-reactive protein. Did you know there's a whiplash protein? There's a blood whiplash protein. Do you know why it's not used? It's only positive in like 16% of the cases, and it has to happen within like 9 days of the injury. So what's the relevance of that test, low or high? Very low. That's why we don't talk about it. It's not very relevant at all.
Are you talking
See?
for the head injury?
Yeah, the head injury, yeah. There's a protein. There's a protein in the blood when you have a head injury. But it's so low that it's not even worth talking about or doing. Because how many tests could we talk about? They're ad nauseum. See, what I try to do is I try to make it real specific and as highly relative as possible to what you see every day, which is the low impact soft tissue spinal injury. Not everything in the world. Okay, palpation. Subjective, hybrid, objective, palpation. Let's go with tenderness. Hybrid. Fixation. Hybrid. Muscle spasms. Hybrid, yeah. Yeah, it's not objective. But when you match fixation, tenderness, and muscle spasm with mechanism of injury, injury magnifier, subjective, correlative, primary indicators, altered intersegmental motion, AOMSI or McNabb's line, and then support it with Dynarom or high C-reactive protein, how relevant is that test now? Now it's very relevant. Okay? Any other tests you want to talk about? Any other tests that you're doing or want to talk about?
When you do a range of motion computerized by AMA guides, does that keep it subjective or would that be more objective?
So the question is, are you doing range of motion computerized? Right? Now when you say computerized, what are you talking about?
Well, AMA says that you do it 3 times and it has to be within
Okay,
5.
you're talking about like JTEC.
Yes.
Okay, so range of motion, according to the AMA guides, so when you use computerized, and by the way, I do recommend this. It's a really phenomenal tool. Is you're using the inclinometer, dual inclinometer, and it's Wi-Fi. I mean, it's Bluetooth. So you don't have wires and cables. So you have dual inclinometer. The dual inclinometer helps to absorb any movement. So the patient moves, it registers. And what's the reason it's done 3 times?
Reproducibility.
Increases the accuracy and the reproducibility. So it's done 3 times, okay, in each motion. So that is very good to use. Now, would you call that subjective, hybrid, or objective?
Objective.
Well, the digital part's objective, but the actual movement is hybrid, because the patient is the one that had to move. When you read it, it's objective, and everybody would read the same number, but the patient can but what decreases, what moves it into more of an objective, it's still not objective, is the reproducibility.
Yeah,
The more times you do it,
I've been challenged 4 times in court, and every time it's always held up as objective.
I'm with you. Okay, watch. What makes it, what pushes it toward the objective? Multiple times. That's what pushes it to the objective category, not just doing it once. But who still controls it? The patient controls it. But the more times you do the test, the harder it is for the patient to be consistent where to stop. That's how it works. Okay? Now, what I just said with you is exactly what I'd say to a jury. What just happened to my credibility by doing that? Remember, I'm totally not afraid to giving away something. Matter of fact, what's the rule I always say? If everything's positive, you better find something to give away, because you're not going to look credible if everything's positive. So I'm totally okay with, and by the way, that's what's so good about explaining this hybrid category. It gives you tremendous credibility when you say, well, no, it's not objective. But also it's not subjective, it's interpretive. It's a combination of the patient's action and the doctor's art of interpretation. That's called hybrid. How much of an authority did I just sound like? How much do I got them now when I go, no, this is objective? You see? And then how much authority do I have when I go, I have all the categories. Subjective, this biomarker, this biomarker, this biomarker. I've got the hybrid, this biomarker, this one, and I've got the objective, this one, and this one. What just happened to my credibility and authority? All because I was willing to do what? Explain the difference and give something up. That's why my credibility and authority shot through the roof. That's not, now you know, that is not what's happening with the average chiropractor. They're doing low sensitivity testing. They have hardly any, they got their cervical sprain strain 6 months later. They don't have any range of motion, essentially, active range of motion. No dermatomes, no reflexes, no muscle strength problems. And they got cervical sprain strain. You know, that's the average soft tissue injury case, isn't it, with the chiropractor? In other words, you got nothing, you got junk. And then the chiropractor goes in there and tries to say that it's objective. Active range of motion is objective, dermatomes, no, it's not. How well is that working? It's not working at all. So I wanted to spend an extra few minutes going into this because it's a way of thinking. It's a way of thinking. And I'd have that chart written out. All your tests you do on the left-hand side, have them written out. Put these categories at the top, subjective, hybrid, or objective. Then put relevance. Now relevance means at MMI. And then put low or high sensitivity at MMI. That's at MMI. Go over that with your, and list it all. Go over it with your attorney. Show them the mosaic. Phenomenal. This is how the whole case comes together. And tremendous credibility. Why it's totally okay to say, yeah, this was normal. Why it's totally okay to say, yeah, the patient came in one day on a scale of 1 to 10. They said they weren't having any problems. I have no problem saying that. Yeah, they said 0. No problem. Right? Because what else do I have? Well, number one, that's called a microtrend. It's one small piece of a graph. Number two, how many other tests did I do? Well, that was just one, subjective. I should have had 2 E&Ms in there. And if I did the E&Ms right, what's the chances that I either have tenderness, fixation, or muscle spasms, one of 3 or all 3, in those biomarkers with the 0 subjective? What's the chances I have it? How many times do you get a patient, they go, how you doing today, Joe? Oh, I'm feeling great. You go and feel them and you got tenderness and a fixation. How many times does that happen? Because their active range of motion was normal. That's why they said 0. They didn't put their body into the overpressure range of motion and stress it with an ADL. Bam! That's what my jury just heard. When the attorney says, well, that's 0, so there must be nothing wrong with them. That's what my jury just heard in the comeback. Because we don't base anything on one. And I understand the relativeness. See? That was just one biomarker in one piece of time. Big deal. I'm looking at all biomarkers in the big picture, not just one.